This
Genetics.
conference will now be recorded.
Start over.
AnCan is grateful to the following sponsors for making our recordings possible: Bayer Foundation Medicine, Janssen Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics. We appreciate their support, and we also appreciate the support for many of the participants who visit ancan.org and hit the button that says donate. AnCan notes that it does not accept sponsored promotions. Any drugs, protocols, or devices that are recommended in the discussions are based solely on anecdotal peer experience or clinical evidence. Please consult your own medical provider for personal medical advice. We encourage you to discuss anything you hear here in these sessions with your own medical team. We are also in the process of generating a list of updated questions that we can take to heart when we meet with our physicians to make sure we're getting the information we need to move forward. Frank, you're going to be up first. And again, I have a questionnaire that I would like to go through with you. I'm wondering if you have a tissue or something around with your camera. It appears to be rather blurred, and I'm wondering if the camera lens is dirty there.
I'd have to leave to go get a tissue. It may be because the room is dark.
Okay.
I think it's
because of the glare.
Yeah, it's that bright spot. I think that's fuzzing all your face out.
Let me move to another room, and hopefully nobody will interrupt me in the house.
Oh yeah, that's better already.
Okay.
Frank, where do you live?
I live in Yorba Linda, California.
Okay, and how old are you?
I'm 76.
And when were you first diagnosed with prostate cancer?
In June, this last month.
Okay, great. What got you to the doc, and what led to making a diagnosis?
Well, I normally visit the urologist annually, but another illness.
Okay.
Because of another illness, I skipped a year, so I went back to the urologist this year, and my PSA went up from about 4.99 to 6. So they did a random prostate biopsies and found that I had a cancer. The readings, most of them were 6, except for one that was a 7. And so
Was
the
the
doctor,
7 was the 7 4 plus 3 or 3 plus 4? Did they tell you?
I've got the report. I think it was 4 plus 3.
Okay, and then the important thing on that would be the percent of 4 in the lesion. If you have the report handy, it might say that. But this was a random biopsy. They did not do an MRI before the biopsy.
That's correct.
Okay.
Since then, I was referred to a doctor for radiation, and it was all this was new to me before the visit or during the visit. So I did a little bit of research, and both the urologist and the radiation doctor recommend I do radiation 20 sessions for 4 weeks, 5 days a week. Since then, I've done a lot of research, and I've seen Dr. Schultz's video yesterday, the one he talks about active surveillance. So I'm interested in pursuing or understanding more active surveillance. I am going to go back to see the urologist this Wednesday on that.
Well, let me, before we get into that, do you have the biopsy report handy?
I can go grab it real quick.
Yeah, it would be helpful to have that to know the percent.
Okay, let me.
Because
I'll
that's
be right
going to
back.
be one of the important factors here. So if you can get it. And I apologize for the leaf blower that you may be hearing here. My wife left the front door open so that we could all listen. So as he's running, I'm going to just do an inappropriate plug. I just published a kid's book this past week, and it's actually very exciting. And we're traveling off this weekend. I have my co-author coming in town, and we're going to do some readings and kids events to push the story in the book.
Okay, so I'm back.
Okay.
The report shows. I'm sorry. Go ahead.
No, go ahead.
So it shows 5 biopsies, I believe. One says 10% at 3 plus 3 equals 6. A second one is 1% at 3 plus 3 equals 6. Another one, a J, says Gleason score 3 plus 3 equals 6, and that's 62%. An E, GS 3 plus 3 equals 6. A K, GS 3 plus 4 equals 7.
So 3 plus. And what do they say the percent for in that core?
11% of total biopsy length.
Yeah, that's how much of the piece of tissue is cancer, but it should also say how much of it is the another percent on that K should tell you what percent is for.
Um, grade 4 compromises 5%.
Okay, great, good.
I don't know what all that means, but
Okay, so the concern that we have here is that a random biopsy is basically doing a biopsy blindfolded. It's less than 1% of the tissue is checked. And without an MRI, we really don't know if those biopsies tell us much about where you are. Um, I think in this day and age, if someone is sent to do a random biopsy without an MRI, it's really information that ought to get them to find a physician who's practicing more up-to-date medicine. The random biopsy, we really don't know what you have, and you really don't know what the worst area is, which would dictate the treatment. So I would strongly recommend that when you get an MRI to see if there are other areas there that potentially need to be targeted for biopsies and that might appear to be more advanced tissue. The other thing that we strongly advise is that 25 to 30% of the time, if you're getting your biopsy read locally, uh, the pathologists are not reading prostate biopsies all the time, and they may be missing and may be telling you one diagnosis when it's actually something else. And between 25 and 30% are actually going to change their treatment based on a rereading. And we recommend Dr. Ming.Zhou at Mount Sinai in New York, or Dr. Jonathan Epstein at Advanced Prostate Pathology, also in New York City, to review the tissue. But I think that at this point, we really can't tell you much other
Mark,
than.
let me jump in, okay?
Okay.
This gent belongs in active surveillance. You got a lot of new guys, so let's just, Frank, let's tell Frank about the active surveillance group. They will give him the references to Dr. Epstein
Rick,
and Dr.
Rick,
Zhao.
yeah, and
Okay?
and
And
and he doesn't have a biopsy that's readable yet.
right. They will move him on. He doesn't belong in this group, Mark.
Okay,
Frank.
neither do I.
Okay, I'm happy to take over. I'm sorry, Frank.
okay.
what we're trying to tell you is this. We have a lot of new guys in the group, and so we want to move you along to the appropriate group as quickly as we can.
Okay.
The appropriate group for you with 3 plus 4, you have 5 cores of 3 plus 3, of 4 cores of 3 plus 3, and 1 core of 3 plus 4 is the active surveillance group. And the reason for that is that you are an excellent candidate for active surveillance.
Well, that's good to
Everything,
know.
everything that Mark has said is all correct. Dr. Mark has said is all correct. But we don't want to be talking about treatment for you because that isn't the right option. On Wednesday at this time, we have a group, and I encourage you strongly to attend that group.
I will.
They will go through with you what was discussed right now. They'll give you all the time you need. They'll tell you how to get second opinions. But given that we have a bunch of new gents right now, we'd suggest that we move on to the next man and you show up in the active surveillance group on Wednesday. We will navigate you. When you're ready for treatment, either surgery or radiation, you'll come back to this group. But our view, especially at your age of 76, is that that's not the way for you to go right now. We can't give you medical advice, but we can say that any man in this group who had your numbers would be looking at active surveillance.
Okay. So I guess I can exit from this meeting, I guess.
Free to stay. You're very free to stay and listen, but we can't give you the best navigation here. The best navigation you'll find is going to be in the active surveillance group.
Okay. And I assume I'll find that in that AnCan website.
Yes, it's exactly the same time as you came in here at 5 o'clock,
Okay.
and it's on Wednesday.
Okay. And then in the meantime, then yes, I'll just listen. I'll mute my microphone and
That'd be great.
then I'll
Yeah.
just listen, and you can move on with the meeting with the people that need more help at this point.
That'd be great.
That's good.
Okay, Dr. John, you want to call on the next man and interview him?
Okay, I don't have the list of who. Tim, I think you said no, didn't you?
Okay, we have a bunch of new guys, I believe.
Oh yeah, that's right. We have new guys first. The other, let's see, Brian on the telephone.
Okay.
You come.
Can everybody hear me?
Yes, we can hear you now.
Okay. So I have the checklist, and so I can just run down all the information on the introduction checklist.
Okay,
If that
Rick, do
would
you want to take
help and
notes,
speed
or
things
would you
along.
like me to? Let me
No.
just talk to my boss here for a second, Brian, while we reorganize ourselves. Rick, do you want me to take notes on these guys and you
Yes,
interview?
please. Yeah, and you can send them to Mark when he cools down.
Okay, then you go ahead and talk, and I'll get my note cards. Okay.
Let me start by asking you a couple of questions, Brian. How old are you?
Okay. 63.
And where do you live?
I live in Potomac, Maryland.
Okay, another Maryland gent. Okay. And when were you first diagnosed?
So I started seeing elevated PSAs starting early in 2024. Had an MRI done in November of 2024. That showed likely cancer in the
So
right
hold on a minute.
apex.
hold on a minute. Let's go back. When were you, sir? When was your first? What was your PSA in 1124?
Okay, so let's see. In June of 24 was 5.5. July 4.8. November 5. And then April of this year 4.2.
So your PSA really hasn't moved around too much. It's sort of in that 4 to 5 area, correct?
Correct.
So what prompted you then to go to the doc, and what prompted the doc to order a biopsy?
So at the Walter Reed prostate center, they said based on those elevated results that they thought the safe thing would be for me to have an MRI.
Okay,
done.
so
And
they figured, let me just understand, they figured that at age 63 with a 4 to 5 PSA, they felt you should have a biopsy. Is that correct?
no, they felt that I should have an MRI,
They felt you should
and that
have
was
an
because
MRI. Got it.
that's because the trend on it went from 2.2 in 2020 to 3 in 2023, and then jumped to 5 last year.
Okay, understood. So they ordered an MRI, and what did they find in that MRI?
So the MRI, the impression statement is lesion 1, right posterior peripheral zone apex, 0.8 centimeter axial T2 series 6, PRADS 4.
Okay, so just summarize it for us, because it's hard for us to, without seeing it in front. They found a PRADS 4 in which quarter?
The right posterior peripheral zone apex.
Okay, right apex posterior. Okay, and how big? And well, we won't get into how big right now. That probably that'll come from the biopsy. And then they ordered a biopsy based on that. Is that correct?
Correct.
And what
That was
did you?
April of this year.
Okay. Well,
Okay, and then
why
the
did
biopsy.
it? Hold on a minute. You had this MRI in November of 24, and it took them 4 months to figure out that you had to have a biopsy. What's
No,
going on?
part of it was driven by my motorcycle touring passion. I was out on the road for like the first quarter of the year, traveling
Okay,
across the
that's
country.
fine. Okay, so that was your doing, and so you decided, even based on that, you wanted to wait till April 25. And what did the biopsy show?
So the biopsy showed. Okay, so there was a number of different positives on it. So the first one is left mid gland, Gleason score 4+3 = 7, grade group 3, involving 10% of submitted tissue.
Okay.
Next one.
Hold on a minute. I need you to summarize this for us. How many cores were positive?
So there was 13 cores. A core is a biopsy sample, right?
Yes.
When you say, okay. And so there was 13 samples or cores taken, and looks like 3 of them were positive.
Okay, so 3 out of 13 were positive.
Correct.
And of those three, one was a 4+3, and what were the other two?
Second one, the right apex, was 3+4. And the third one, right post apex, was 3+4.
Excellent. And what
I'll
was the
take, I'll take notes, Rick. You don't have to worry about note taking if you don't want to.
Okay. Do you want to continue in the hot seat?
No, you go ahead. I just don't want you to have to be distracted by note taking
Okay,
unless
no,
you
I'm
want to.
doing fine. And
Okay, very good.
so that I remember what he said, I got to write it down. Otherwise, I'll forget what he said, you know.
Yeah.
Okay, so 4+3, 3+4, 3+4. And what was the biggest percentage of 4 that showed up?
The biggest percentage of
Yes.
4.
So if you look at those, at each one, it'll tell you what percentage was 4 and what percentage was 3.
So, so what the report says, like the first one that was 4+3, it says grade group 3 involving 10% of submitted tissue.
Okay.
And then the second one for the right apex, there's actually 2 percentages listed there. It says prostatic adenocarcinoma with mucus features, Gleason score 3+4 equals 7. And then in parentheses, it says 25% grade 4, comma, and then in parentheses, and it says grade group 2 involving 40% of submitted tissue.
Okay. And how long was the submitted tissue core? It should tell you the length of the cores in there somewhere. It'll be probably something like 3 centimeters or 4 centimeters for the total length of the core. More important than that, let's go back to the 4+3. They don't give you that same detail on the 4+3, what percentage of the core was 4. They do it for the next core, but for that one, it sounds like they didn't give you that.
Yeah, it does. Yeah, all it says is Gleason score 4+3 equals 7, grade group 3 involving 10% of submitted tissue.
They need, what you need is the same sort of detail that they're giving you on the next core. And you also need to know, it would be helpful, how long each core is so we can figure it out. Are we talking about 3 millimeters or 3 centimeters? Because otherwise we don't have that information. And I think you can go back and find it out because it affects your treatment. So these are issues to go back to the pathologist at Walter Reed. Did you arrive at this group through Captain Jim?
Yes.
You did. Okay, fine. So I think you can go back to Walter Reed and ask them specifically how long are these lengths? Have you had these cores reread? Have you had these samples reread?
Not that I'm aware of.
Okay.
No one has said that they have.
So you need to order that, not them, and you need to tell them, let's send them out, let's get them reread, because if we're going to talk about surgery, then probably doesn't matter. If we're going to talk about radiation, it can matter a lot. And if that 4+3 should actually, it turns out to be a 3+4, that could have a difference in the treatment that you're given. So we would say reread the course. Somebody in the group will post in the chat, oh, you're on the telephone. Jim Marshall will send to you, because he has your details, he'll send to you the how to contact Dr. Epstein or dr.Zhou, one of those two pathologists, and we'll get a rereading of your core. It's important.
Okay.
Now, what are they suggesting you do next?
They at the seminar they had at Walter Reed, they kind of laid out the different the two different options between the surgery versus the radiation treatment, and I kind of felt like I was getting nudged towards the surgery option. But then in something I recently read, so I have a meeting with Dr. Chestnut, who would be doing the surgery on Friday,
Okay.
because I had recently just read that about something called HIFU, which I guess is a high frequency acoustic waves that are used, and that's supposed to be a very highly successful
Not for you.
process.
Not really
No?
for you. If you're a 4+3, definitely not. And we have to distinguish here, because you would be looking at HIFU most likely for the whole of the gland, not as a focal,
Mm-hmm.
not really a candidate for focal. You'd be looking at HIFU for whole of the gland. I mean, it is an option, but I'm not sure any of us would say take it over surgery or radiation. I want to throw this out to the group because I want some people to talk to you about their experience from surgery and their experience from radiation. And if there's anyone else here new, they should chime in. So how about Colonel Boykin? Do you want to start and talk about your what you now know versus what you did know?
Sure.
Did you start at Walter Reed,
Yes,
Boykin?
yes, yes. I had all my treatment at Walter Reed. So I had my prostatectomy in October of 2024 with Dr. Chestnut. Um, I thought everything went well with him. I kind of went through the same scenario. Brian, it seems like you not maybe didn't ask all the right questions in that group, because at least my experience was is that they're pretty balanced when they do those things, and they're just laying out all the options. What I will tell you is that if you show an inclination already to go one way or the other, then the doctors will just let you go that way. They don't the surgeons versus the radiation guys are not begging for patience. They if you say I want to go, they're presenting the options, and if you start leaning towards one, then unless there's some compelling reason to override that, they don't push back and forth. So I think they leave you on your own with respect to that, and I'm not sure how much you explored all of that. But I ended up having to get, even though I chose surgery, I had to deal with the erectile dysfunction and still deal with all of that stuff like all these guys do. Um, and I also then had to go get salvage treatment but I was a Gleason score 9, so that was a difference, with some other health issues that I was concerned about as well. But on the radiation side, the treatment was great. There, for me, might have been because of my other health issues. I also ended up with radiation cystitis coming out of the radiation, but I got cured as a result. So I had to go the full treatment. Well, cured is a bad word. I didn't really mean that. I mean I'm in remission. Um, but I but I've had to do all three. When I say that, I mean I did the surgery, I did the radiation, and I did 6 months of ADT. And so I'm on track. And all this started about, like I said, in October 2024, or maybe October 2023 now.
Jeff, you wanted to chime in?
Yes, Colonel Boykin made a comment that I would like to mention is not my experience. Um, I don't know if it's helpful to give you my lowdown here first or just give you the comment. The comment is I found quite the opposite. I found I was being directed when I was referred to the urologist strongly to surgery. And when I pushed back, he gave me a referral to a radiation oncologist, and 6 providers total got me into focal therapy. So I would say be very careful with trusting people who are surgeons to say, yeah, you don't need surgery.
So can I just ask you, Jeff, were you treated at Walter Reed?
No, no,
Okay,
I'm in
so
San Diego.
okay, so this is difficult. I mean, I tend to agree with you, but I would say that depending on where you go, you're not going to get that balanced opinion. In some places, you will. I Walter Reed, Walter Reed tends to be very biased towards surgery, but maybe not for everybody, and maybe not for Boykin. Were you treated at UCSD?
I was.
Yeah. So if you go to a center of excellence, you're going to get that balance. Also, they're going to refer you to focal if you are a candidate for focal,
Correct.
right? If you go to a community provider, they may offer you focal when you're not a candidate for focal. So you have to be really, really alert. That's why we run this group, because we find people doing focal who shouldn't be doing it. I don't want to get into your details right now, but focal is really, really specific. You have to have, there's a very narrow band of disease demographics that are appropriate. 3+3 is very appropriate for focal if you don't have too many cores, but there again, 3+3 usually doesn't need treating. We've got a guy right now, we've got 2 guys, one with 11 out of 12 cores, 3+3, and another with 12 out of 12 cores, 3+3, and neither of those guys are thought to need treatment by some of the best urologists in this urological oncologists in the country. So focal is very, very tricky. But that's sort of taking us away from Brian. Does anybody else have any feedback for Brian in trying to make this decision? Bill in Virginia and Stuart. So let's start with Bill.
Yeah. So Brian, I'm also being seen by Dr. Chestnut. I'm 3+4, about 10% of my 4. And for watching this about 2 years, I would say that he looks at treatment based on, honestly, maybe 1,000 surgeries he's done there. Like Colonel Boykin said, there's no shortage of patients that he sees. I think
Mm-hmm.
he bases his recommendations on kind of taking this all, the scores, what the MRI looks like, and his interpretation of whether he would have to go back in and try to fix up something that didn't work out with another treatment. I think Rick's assessment's probably fair. He looks at surgery like, because he's a surgeon, but he's a very gifted surgeon. So that's that's where I think he's coming from. I'm active surveillance. That's what he agreed with me that was the best for me at 3.4. 4.3 may be a different calculus for him.
Mm-hmm.
Stuart.
Yeah, hi, Brian. I'd like to sort of come at this from a slightly different direction. I know there's a lot of focus in terms of surgery or radiation. But I think one of the things that you really also need to think about is what's important for you in terms of how you feel about what the options are and what ramifications of that you need to deal with, considering both surgery or radiation, in terms of you're making a decision that you're going to have to live with, easily 20, 25 more years. And that's, you really comes down to where you feel fit on that scheme. And, think about with surgery, there are a bunch of potential side effects that you could experience right away and could very well last with you for a very long time. And the alternative in terms of with radiation, in terms of the fact that depending on exactly the radiation that you need based on your diagnosis, might be that you have a fairly mild side effects short term, but have a risk of longer term side effects that could come back over the next 20 years. And really, it comes down to what you're comfortable with. And that should play a big part in terms of, really don't look for the doctors to tell you what to do, because they don't know you and they don't know what really makes you comfortable at night when you put your head on the pillow. And that has a big part to do with this. It's a big decision, and it's something that you really got to feel like it's right for you. And, I would be talking to doctors at multiple locations, not just at Walter Reed, and make sure that you're getting the right info before you pull the trigger.
Mhm. So I'm assuming that I shouldn't assume, but do you have TRICARE?
Yes. Yeah, I'm retired Navy.
Yeah, so it's not hard for you. I mean, you have access to any doc you want. And I think that Stuart's advice to get a second opinion from probably from Sibley, which would be, I mean, 6 of one and a half dozen the other. Either go to Sibley or go up to Baltimore and go to Hopkins, because Sibley is Hopkins now. I can't tell you. I don't have the surgeons. Oh, I think we could probably recommend a couple of surgeons at Hopkins. Not right now at Sibley, but we could find out. We've got some good contacts at Sibley, and we could ask them who they like. But I would be thinking, yeah, get a couple of second opinions. Get your slides reread. Really, really important. If you're a 4+3, then you're not a candidate for active surveillance. If you've got 3 cores of 3+4, you're still probably not a candidate for active surveillance. You'd be pushing it. So you do need treatment. But, we've got to decide, are you better off at Walter Reed, or are you better off at a center of excellence? Now, one thing I definitely would suggest you do is run the MSK nomogram. If you're familiar with that, John, do you have it? Can you put it in the chat window?
I'll look it up. Yep.
Oh, wait a minute. You're on the phone. This is why we encourage people to come in on the computer, because it saves us a lot of work. Captain Jim, do you have the MSK nomogram? Okay, so when Jim sends you those references for Ming.Zhou and for Jonathan Epstein. He'll also include a link to run the MSK nomogram. Now that nomogram, and we will put it in the chat window, John, if you can still do it, because when people listen to the recording, they'll be looking, they'll want the link. It is based, do you know what a nomogram is, Brian?
Yes.
Okay. So, well, for those that don't, it's a very large database taken from a select audience, focus group. And in this case, it predicts how successful your surgery is going to be and how likely it is that you'll need further intervention. So if Colonel Boykin had known to run the nomogram before he committed to surgery, he probably would have seen there was a very high percentage that he would need radiation later because he went in with a 4+5. In my own case, I walked into my doc back in the day, and the first thing he gave me, he was a urologist, was the nomogram. This was back in 2007. So I knew from the very beginning that if I wanted to do surgery, there was not a real good chance that that would give me a durable and continuing remission. We don't talk about cure because when you got a 4 in your number, we don't know how to cure prostate cancer. We only know how to cure 3+3 prostate cancer, as Boykin remembered. We don't have that. And if you challenge a doc who says 4, 9 times out of 10, they're going to retract and they're going to say, oh, yeah, well, a durable remission then. All right. So,
Rick, it's
go
John.
ahead.
I thought I would try to push you along because you have a lot of newbies to get to.
Okay. Oh, thank you.
I just wanted to get the last word for Brian, which is that
Yes.
if you cancel your surgery this Friday, you might be worried that canceling your surgery is going to doom you to the cancer taking over. But it will be okay. It's not such a fast, aggressive process at all that losing a couple of weeks to get a second opinion, to get a better look at the
So
biopsy.
my surgery isn't scheduled until the 29th of September.
Oh, I thought you said this Friday. I'm sorry. Okay, very good.
Yeah.
We'll
And
we'll
so,
we'll get some work done
yeah,
before then, so you can make a good decision.
come back in. We'll direct you to some other people. If we don't have good names at Sibley, maybe Captain Jim can reach out to Dr. Palla and ask her who she likes for radiation and who she likes for surgery at Sibley. We can do
Okay.
that. Okay, and
Wow,
because
this is all really great stuff. I really appreciate this. Gives me a lot of good stuff to talk with my with Dr. Chestnut about on Friday.
Oh, that's what was Friday.
Okay. Now, who else is new, Dr. John? Jeff is new. Okay, Jeff. Please step. Jeff, have we seen you before in another group? I seem to
No.
think I have. Okay.
First meeting.
Okay. Welcome.
Thank you. So here's the nutshell. 69 years old. PSA went from 3 to 4 between 2003 and 2023 and 24. So I was referred to urologist number 1, had an MRI, 1 PIRADS 4 lesion, 5 by 9 millimeters, posterior lateral base, right peripheral zone, 30 cc volume, 0.14 density. March of this year.
Let me just hold you. Repeat that again. You had the biopsy showed one positive core?
No, the MRI, I didn't talk about biopsy yet. The MRI showed 1 PIRADS 4 lesion.
Okay.
And it was posterior lateral peripheral zone.
Posterior lateral peripheral zone, apex or base?
Base.
Okay, that's really important, by the way, guys, because
Right.
the base is a lot more dangerous than the apex. Go ahead. Sorry.
Biopsy was in March, 2 months later of this year. 2 of 7 cores were positive. And I had the biopsy reread, so I'm just going to skip to the reread. I have 2 lesions that are both 3+4. One is 30%, pattern 4, and one is 20%. And so that dropped me to improved me to intermediate favorable. And where I had been intending to pursue radiation at that time, I ended up going to, I think I was at provider 4 by this point, which was City of Hope. And I spoke with somebody about focal therapy. HIFU was what he did. And in my previous comment, I made the remark that the initial providers did not tell me anything about surgery and then radiation. This guy did. City of Hope is about 60 miles from where I live. 30 miles from where I live is UCSD, and it occurred to me why I didn't go there first initially, I don't know, but I ended up at UCSD. I had IRE performed last week, Wednesday. Tomorrow I get the urinary catheter out. I'm told it went well. There was a repeat biopsy before last week's procedure. It showed that the lesion in 5 months had grown a little bit from half a centimeter by 1 centimeter to about 1.1 by 1.2 centimeters. The volume had increased a little bit from 30 to 34 cc's. And so I made the decision that.
Hold on just a second. Will you explain for the guys what IRE is? Because I'm sure there's some gents in here who are wondering what the heck is IRE. I know one gent who is not wondering about IRE is for sure, and he'll talk to you momentarily. But
Sure.
Would you please, for the benefit of everybody else, explain IRE?
Sure. When I explain this to the uninitiated, I tell people that if you put it into 2 baskets, you treat the prostate either whole gland with the radiation or surgery, or you treat it focally if you're the right candidate. As Rick pointed out a moment ago, that's really key. So focal therapy is like the word suggests. You are using some form of energy to treat a focal area of the prostate, and the choices are heat with ultrasound, cold, cryo, or electricity. And IRE is the electricity. It stands for irreducible electroporation, and it basically has them place somewhere between 2 and 6 needles through the skin into your prostate. They set up an electrical field, and it's not really accurate to say they electrocute the cells, but it is really cool technology. They perform I should add this, it's also referred to as nano knife, and the nano comes from the measurement of a nanometer, which is a billionth of a meter. And so they make a hole in the cells that are treated the size of a nanometer, and they basically disrupt the cell's homeostasis. And effectively, your immune system takes over, and the macrophages come in and they eat it up. It's not like radiation where they kill the cells slowly. Anyway, we'll see how it goes. That's where I'm at, and I'll stop there.
Okay. I have a couple of comments on that, but I would love to go to Stuart because I'd love you to hear his thinking. He had a somewhat similar diagnosis. Stuart, over to you, sir.
Hi, Jeff. How you doing?
Good, thanks.
As Rick alluded to, I had IRE as part of a clinical trial. My treatment was last September. First question: Are both of you 3+4s on the same side?
Yeah, they're adjacent.
Okay. And do you know by chance what percentage of that lobe was treated?
I don't. I will. I probably won't know that for 2 weeks when I see the urologist again.
Okay, because in my case, uh, I was treated in New York City at Weill Cornell. 25% of the one side was what was treated, and similar to you, I had a catheter for just short of a week, and relatively slow recovery. I had blood in my urine for 5 weeks, and once that recovered, since part of my clinical study, they just went ahead, and I also had SBRT radiation because the clinical trial is trying to lower the risk of recurrence, which is really my question: is what did they tell you to expect your risk of recurrences?
Don't know the answer to that.
I would ask your docs what their experience has been.
It appears there isn't anybody else locally in the group today. I had a very checkered experience with the 6 providers that I went with. Ultimately, at UCSD, I think they did a fabulous job. Their communication, on the other hand, is in the toilet. They don't do a lot of hand holding, and you have to be a very strong self advocate and ask the questions if you want to get any answers. And I can live with that, but
Hold on a minute, because there may be other people. I don't know. We haven't asked, and I know there's a couple of people that join from south of Los Angeles. I don't know any. Is there anybody from the southern part of California who's on here today, other than Jeff? Put your hand up if you are. If not, Jeff's totally right. I guess, and I know we're pressed for time, I guess what there are 2 things we'd like to do. Stuart, how many cores of yours were positive?
I had 3 that were positive, 1 that was 3+4, and the other 2 were 3+3.
Okay. And so basically you were somewhat similar to Jeff. Would you tell the reason, I mean, it's water under the bridge, so you've done what you've done, but I think the reason that Stuart went for this trial was exactly the reason he asked for you. He wanted to know what was the success rate with the IRE. The problem that we see with focal is that it basically is it's only successful and the disease doesn't come back 50% of the time. It's probably higher than that if you just were to filter out the people that had a 4 in their number, because they do treat a lot of people who are 3+3s who might not need treatment. And so what we tell people in this group is, if you want to do focal and you are a candidate, and you were definitely a candidate, there's only a 50% or higher or lower chance of success. There's a 50% or higher chance that it will recur. And sadly, we've seen a lot of those guys who come back and they finish up in the high risk group, because when it recurs, they've got worse disease. And the reason for that is that we don't know where else it is in your prostate. We can't see it. So if there are any of those little 4s that have gotten out, they could be breeding, and we won't know until we see him. On the other hand, you could be one of the lucky ones and it worked fine for you, and there are plenty of those guys. If you Google our website for focal therapy, you'll hear a couple of good presentations that we've done on that. So that's why Stuart's drilling down. And believe me, Stuart was in the active surveillance group for a long time, and he listened and he did his homework. And that's why he decided, I'm going to do IRE plus, I'm going to treat the whole gland. So that would be our feedback for you, Jeff. We're here to support you. I'm curious if you have any questions for us before we move on to the next gent.
Probably I'll hold off to save time because I don't know much more than I've mentioned, and Stuart's questions were good. And like I said, I just haven't had the opportunity to ask those questions yet. So I'll hold off until a future meeting after I've had the follow-up consult. Thanks.
Okay, great. Have you signed up for our reminders?
Yes.
Great. Have you done any genetic testing? Did UCSD or City of Hope encourage you to get genetic testing?
Yes, my Decipher is 0.51.
I'm talking about not Decipher, but either whether you have any mutations like.
Oh, excuse me. Yes, I did the Promise registry,
Good.
and I do not.
Fantastic. Okay, because we would have given you a link to Promise, but you're all good. Okay, we're going to move on.
Rick, could I just ask Jeff a couple
Yes,
of very
of course.
quick questions?
Sorry.
So you said there's a consult coming up. Could you remind me when and where?
Yeah, it'll be July 24th, so a couple of weeks.
With who?
With the urologist.
Okay, and if you're comfortable with it, so I can tell you from our other Jeffs, are you okay giving me your last name?
Sure. I'll spell it. P as in Peter, Ollard.
And could you say your age again? It went by too fast for me.
69.
Thanks a lot. Go ahead, Rick. Sorry.
And you're looking good, Jeff. Just want to say. I'm sure you exercise. I can see it in your face. So, who else do we have that's new? Sorry that I've got to ask, but I didn't have the list. Okay, we have a gent in a purple shirt whose name is Victor. Hello, Victor.
Hello.
You've got the outline. Let's go. Tell us how old are you? Are you ready, John? Or John, would you like to do this one? John, John, please, would you do this one? I'll help you.
I could probably save you. I'm 63. I could probably save you some of the questions. Yeah, Pittsburgh, Pennsylvania.
Okay. And when were you diagnosed?
I was diagnosed in 2019 when my PSA started to go up towards 4. I had a biopsy, MRI that detected a lesion, and I've had 3 biopsies since then. My Gleason score is 3+3. My PSA continued to rise from 4 in 2019. Oh, and it was a PIRADS 5. And it was localized mostly in the left medial of the prostate. My PSA has continued to rise. It went up to 10 in December, and that's then what led to a pause on the active surveillance and considering a additional treatment. So I had a radical prostatectomy in May, and I had everything removed, the prostate and the vas deferens and the seminal vessels. And I thought that was going to be it because it seemed like everything was contained in the prostate, although the last biopsy indicated that it was also on the other side of the prostate. But what was surprising was the pathology said I had a Gleason 3+4, and 25% of the tumor was Gleason 4. And the carcinoma was both in the right and left lobes. And while it said there was no evidence of extracapsular extension, they said that there was some perineal perineural invasion, and the carcinoma extended to the left anterior bladder neck and left anterior prostate resection margins. So they also removed a lymph node, and that was negative and no indication of metastatic spread. The pathology put it as a T3A. So I'm in a situation where I went for a post-op to the surgeon, and he didn't. This is a situation where great surgeon but terrible doctor. I said he had, it was obvious he hadn't read the pathology exam because I pointed out what it meant, and he was pretty dismissive about it. He said, "Oh, the sections looked clean when I did the surgery, and sometimes the pathology exam is wrong."
Victor, I want to cut you off right there, because if we're talking about what to do with the T3A post-surgery, this isn't the right group.
Okay. Well, that was one of the questions I had.
Yes,
Okay.
and I'll come back, but just tell me again, because I missed it, and Dr. John may have missed it, and we'll need it. Why did they? Where was the cancer outside of the gland that made them classify you a T3A?
It said it was left anterior bladder neck and left anterior prostate resection margins.
Okay, so it was in the margins and in the bladder neck. Bladder neck's kind of interesting. I would ask you, and I want to get somebody. I'll make a call later and try and get somebody into the group tomorrow. We'd like you to come back tomorrow if you can at 6 o'clock Eastern in
Okay.
the same room. Okay. And Dr. John will be leading the group tomorrow. That is our recurrent group.
Recurrent. Okay.
And that's where we talk about issues like this, because we don't want guys in here to be thinking that their choice won't succeed.
Right.
That's the reason we do it like that. Just the same way as we don't want the active surveillance men to listen to treatment discussions, which is why I jumped in and we gave Frank the option to stay
Okay.
or to go, but he didn't. We didn't think it was right. Now, I have a guy who has had issues with bladder neck, and he's the guy that I would try and get into the group so he can talk to you about what maybe he should have done and he didn't. And that will be a much better discussion for you tomorrow. So we hope we can see you tomorrow, and I would try and get Jeremy into the group for tomorrow. I'll send him a note and say I've got a guy coming in who's got bladder neck issues.
Thank you. Appreciate it.
And
for those
do
who
you have a post-op PSA yet?
Yeah, it's 0.06. 6 weeks out.
Yeah.
Okay.
Which is not good. It's not bad, but it's not what I expected.
It's not good.
Yeah.
So definitely go ahead, John.
Yeah, your next one may be higher and may even be lower. Let's see how the 12-week one is, but we'll treat you as a recurrent person at the present time, and I'll bring you into my group tomorrow. Finish the rest of the interview, and
Okay.
could I have your email?
Sure. It's my first initial last name, so Siclari at Comcast.net.
Great.
Okay.
Are you signed up, Victor?
No, I
or
wasn't. To be honest, I wasn't sure whether I would be appropriate for this group or the other one, because I'm kind of, it was in the middle.
Right.
And
No, fair enough. So Siclari at Comcast. I'll sign you up afterwards. I'll send you.
do we lose somebody?
Uh-oh.
Rick happened to burp.
Yeah.
Rick just disappeared. When's your 12-week PSA due?
Let's see, it's been about 8 weeks, so another 4 weeks. I'm going to see an oncologist first and then the surgeon. I've already
Oh,
kind of skipped.
who's the oncologist you're going to see?
Dr. Applebaum. He was recommended by someone who's connected to this group. I can't remember exactly who, or maybe it was.
Sorry, I'm back. My computer defaults me at a certain point in time. I don't know, but it happens. We know Leonard Applebaum very well. You can even tell him you're an AnCan guy. We've had several guys that have seen him, so that's you're with the right doc.
Good.
At UHB, so or
Great.
UPH, UPH,
UPMC, yeah.
UPMC. Yes, thank you.
So
All right.
Okay,
just
great.
a plug for the rest of the group. Active surveillance, 6 years. Don't have
Oh,
any
great.
regrets.
Oh,
right?
man.
2019. I went through
Yeah.
I went through the MRI, I went through the biopsies. I had multiple biopsies once about every 18 months. I had the Prolaris test to evaluate biomarkers, and I was at low risk. And in hindsight, maybe I should have had it out sooner because maybe it wouldn't have gotten out of the side of the prostate. But it's one of those things where you make decisions that's personal, and I just wanted to push off the surgery because I was concerned about the side effects.
Okay. All right.
Well, hopefully that benign history will mean that it's not going to behave too aggressively in the future.
Yeah, that's my hope.
Jim,
well, thank you, gentlemen.
Question, Victor, are you a veteran?
No, I'm not.
Okay. Thank you.
Okay. Any other newbies?
Oh.
That's what we call you. We're not being rude, Victor and everybody else. Eric Tavela, are you a new person?
I'm a new again person. I've been here a year ago and back. If there are new people who need to go, please do so. I need to get in the car in about 20 minutes, so I was hoping I could go early.
Okay, thank you for telling us. John, do you have a list of, I thought I recognized you. John, do you have a list of the people that need time?
Nope. I didn't quite get to it when Mark showed up.
That's okay. If for one moment, anybody who needs time, can they please use the little hand in the bottom left to put their hand up so we can make a note of everybody who needs time tonight? Eric, who else? Anyone else need time? I see somebody waving their hand. It says Dr. Mark Perlow at the bottom, but I don't think you're Dr. Mark Perlow.
I was unable to change his name.
Oh, you're unable to change his name. Well, let me help you. At the bottom of the screen on the left-hand side next to the record is a hand. Please press that. Bottom of the screen on the right hand. Got it. Thank you, Paul. Okay,
right.
so
can you hear me now?
Yes, we can hear you now. Okay, so you'd like some time. Eric would like some time. Oh no, sorry. Who's the gentleman who just spoke up?
Robert.
Robert. Robert would like some time. Robert, you're not the. Well, I think I know
I'm
you.
not Dr. Mark. It says Dr. Mark under my face.
Right. Okay, but you look like somebody who I know has more serious disease. That's what I want to make sure. Hopefully not, but we'll come to you. So we've got Robert, we've got Paul, we've got Eric. Anybody else?
I'm Carl, but I'm not ready for today. Next time.
Okay.
Oh, okay, Carl. But you've been with us before, correct?
I was referred back to this group.
From the active surveillance group?
No, from the
high risk.
High risk, which
that's where I recognize the name Carl from. But you don't want to talk to us today.
No, I just had my MRI yesterday on Friday, and I didn't get the results of that yet. So, plus I'm on the phone today, and
Okay. Okay. All right. Well, we've got a show. We're going to get around everybody. Oh, and Greg Burns. Oh, my man. And Greg Burns would like some time too. So, John, if you've got list of all of those, I'll let you. Why don't you start with them, and I'll stay quiet for a while. Start with Eric because he's got to go. Please.
Okay, Eric, what's on your mind?
Appreciate that. I'll do a real fast forward to the early boring part of the story and get to the interesting decision point that I'm at. So a year ago, I was a 3+3 Gleason that was being steered towards surgery, and y'all helped set me right. So I was on active surveillance for about the last year and a half, really. In March of this year, I got to a good doctor, Dr. Amling at OHSU. I had an MRI and then a fusion biopsy shortly after. That was February and then March of this year. So the biopsy, fusion biopsy, 3+3, mostly benign in the left medial apex, 3+3, 6, 5% of tissue. And then in the region of interest, which I assume is also LMA, just where growth was identified. 3+4, 10% pattern 4. This was 3 or 3 cores in the region of interest, 70% of total tissue. And the more interesting thing on top of that was I would say I had germline testing done through the PROMISE registry, and everything came out happy on that, no mutations. Also had Decipher done on the 3+4 sample, or one of them anyway. And this is where it gets interesting. That comes back as high risk. So I'm a 0.87 on the Decipher. So in talking to my to Dr. Amling, it's like, well, you can go another year on active surveillance. You'd probably be all right. Sort of gently steering me towards surgery at that point. I think I was steering myself towards surgery, talking to him. Also saw a radiologist just to do full due diligence. The radiologist, his opinion was being a 3+, like you're still a 3+4, still could consider active surveillance. Like his opinion was the Gleason is what you base that on, and the Decipher is giving you some additional information within that range. I'm also sort of hesitant to do surgery because of the side effects and all that, but I'm also, pretty young guy, pretty fit. So these are kind of the factors, and I'm having to weigh, do I do surgery sooner or later? One more complicating factor is that I'm trying to get Peyronie's disease treated, and I'd like that dealt with so there are no additional erectile complications, and maybe have a little clear path for a little while before all this goes down. That's been difficult just because of our lovely medical system. But hopefully we'll get that treated in the next 3 months. So I know that was a lot. I can go into any more detail if necessary. So again, I'm looking for additional feedback, experience, especially with the higher Decipher score on a 3+4.
Yeah, every once in a while we run across a situation like this where all the clinical and pathological evidence is pretty benign and consistent with active surveillance. Mm-hmm. And then boom, you get one biomarker which is completely at odds with all the rest of it.
Right.
And so do you let that one biomarker alter the course of treatment, or do you go with the 3 or 4 different markers that would say that you continue with active surveillance? Mm-hmm. And sometimes recently, Decipher scores have come out with a more detailed and advanced report than they used to come out with. It used to be you'd get that 0.87, and that's pretty much all that you would get. I forgot, Rick, what's the name of that more advanced experimental Decipher score? Starts with a G, I thought.
Great.
Genomic.
No,
The
It
grid
was called
report.
GRID, I believe.
The grid report.
Grid.
I do
Grid report.
have 5, 10, 15-year, 5 and 10-year metastasis risk based on the score, and 15-year mortality and risk of adverse pathology. Those are all also like interesting numbers that make me, I don't know, like 12.6 15-year cancer mortality after radical prostatectomy.
yeah, I wouldn't mind actually taking a look at that grid report and seeing whether it seems to pile on evidence to add to the original report or not. As some of the guys in here will tell you, a radical prostatectomy is quite a major operation with lifetime potential consequences. How old are you?
I'm 56.
Yeah, and you're a young guy, so you certainly don't want to take that on lightly.
Exactly.
So I can.
Sorry.
Um,
do active surveillance for a year at least, see how we do. Getting PSA readings I know that's not the be all and end all, of course, but every 3 months, and then follow up the biopsy at that point, and then see where we're at. I'm not in a hurry to do surgery, basically.
Yeah. So you talked to a radiation oncologist, and they didn't think that you should jump in with radiation, right?
Right, and they agreed with the surgeon that surgery is probably a better approach. And
Why did they say that surgery would be better than radiation?
I think I have to check my notes. The thing that I recall talking with both about it is that radiation is an option post-surgery, while the inverse is not the case, right?
I don't know if we would necessarily go along with that. It would be nice to have a really expert opinion about how much attention to pay to that Decipher report. But you haven't seen a medical oncologist yet, and that's because you haven't really needed to see a medical oncologist yet. Are there any other biomarkers that we could invoke to break the tie here?
All I could tell, 4 PIRADs, just identifying and confirming the left medial apex. I can tell you PSA scores. We bounce around a little bit, but so I was a 5 point, when all this kicked off, this was the reading that got me here. 5.8 December of 2023, 4.36 July of 2024. It's going to bounce around a little bit. 6.32 in October of 2024. Extra test in December from physical of 4.63. January of this year, 5.09. April of this year, 6.67. June of this year, another extra test from a trial was 5.92.
So basically, the trajectory of your PSAs is that you do not have a rapid doubling time. Right. That's another potential biomarker that can be used to make a prediction.
Really only doubled in 7 years since a 3.3 in 2018.
Yeah. Very benign. Okay. Anybody here have a comment? Anybody here has had a Decipher score that guided or contradicted their treatment?
Stuart has his hand up.
Yeah, hi, Eric. I did, my profile was pretty similar to yours.
Mm-hmm.
My PSA wasn't quite as high, but I had 3+4 with a relatively high Decipher.
Mm-hmm.
And where are you located? Where do you live, Eric?
I'm in Portland, Oregon.
Okay. Well, have you been able to get to a center of excellence?
Yeah, OHSU, I believe. I'm actually not totally clear that they are. I believe they are. I know Dr. Amling is well regarded, and I think it may have been this group or Reluctant Brotherhood.
Okay.
You get to him.
Yeah, their OHSU is an NCCN center.
It is okay.
Yeah.
Yeah,
Go ahead, Stuart.
Sorry. I had consults a number of centers of excellence in New York City, and everybody who looked at my numbers and with my Decipher, what they ended up saying was you could, you were perfectly good to stay on active surveillance, but their general feeling was is that the Decipher was high enough that there was a pretty good chance you were going to have to treat at some point.
Yeah.
And it was a matter of deciding personally how fast you wanted to treat. I'm a little surprised by and would prefer that you talk to at least one other radiation oncologist before determining that you need to go for surgery, because that doesn't sound right. And I know that there's this one school of thought that says because you're younger, that favors surgery as opposed to radiation, and that may be a false statement. And the reason why they say that is because you're younger, your chances of recovery or lack of complications from surgery are less, but that may just be a function of age.
Mm-hmm.
So
yeah, that's what I'm afraid of too.
So
Jim Marshall, you have your hand up.
Yeah, a question, Eric. What kind of history of cancer do you have essentially in the family? Anything at all?
My mother, ovarian cancer very late in life, but no other history that I'm aware of.
Okay.
I think my ovaries are okay. But,
yeah.
Well, some things do run across different cancers, some
right.
genetic abnormalities, but you had a promise test and it didn't show anything.
Right. And Jim Stewart, and then we'll move on. We can move on.
I just wanted to really encourage you to get the germline testing. Our paths were kind of similar. My mother did.
I did, and that all was good. Nothing.
Okay, good. Yeah. Because my mother died of ovarian cancer too, and I ended up being BRCA2 positive, which changed my whole course of treatment. But okay, you've already got it done. I'm sorry.
Yeah,
I didn't
Jim.
hear
He got a promise test and it came back negative as the result. We advised him the first time when he told us this back about a year ago to get a promise test.
Okay, all right. Very good. Sorry, I didn't hear that.
All right. I guess our feeling is that we would hate to see you get a radical prostatectomy on the basis of that, in contradiction to all the other biomarkers, and get some more really expert opinions. Okay. Fair to say, guys?
Yes.
Okay. Go ahead and move on, Rick.
Much appreciated. Thanks so much.
It's a pleasure. And Eric, if OHSU is tricky right now because they're without a leader. They've lost a lot of really good people.
Right.
So it's tough. If you want to get another really good quality second opinion, the two closest centers of excellence mean you've got to travel either to Seattle or to San Francisco from where you are, or to Salt Lake City. Huntsman's very good too. If you decide that's what you want to do, we can do our best to try and connect you. Certainly, we can connect you to RO, radiation oncologists and surgeons at UCSF. I think we can also, yes, we can at Seattle. Not so sure about Huntsman.
I'd like to take a look at your grid report, Eric, if you wouldn't mind mailing it to me.
Emailing it.
Emailing it.
Dr. John put his email in the chat window for you.
Okay, will do.
Thank you.
One last question, which is recommendations on how to go about finding an oncologist to speak to specifically.
A medical oncologist?
Yeah.
John, do you think, I'm asking Dr. John, Dr. John, do you think a second opinion from a medical oncologist would be appropriate or not?
Yeah, sure. They don't usually see people at necessarily at your stage, but since you are even considering the possibility of further treatment, I don't see why. You shouldn't, radiation oncologists should be very good at this question as well.
Yeah, and I would push it. It can be difficult to get somebody to see you.
Right.
When you call in, they'll say, "Oh, they won't see you." Da, 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 da. We have connections. We can probably make it happen. But I kind of like Dr. John's idea of seeing a radiation oncologist, because then you get two for the price of one, because that'll also counter some radiation input on treatments. And yes, we know radiation people at all three of those. But again, our best advice, our best connections are at UCSF for radoncs. But I know I do recognize some names at both, and we've had guys see people at Hutch and also at Huntsman, so we can get your names. You just send us a note as to where you'd like to go. Paul N, ask Eric your question.
I have not looked into. Yeah, Arteria.
Okay, go ahead. Sorry.
I have not looked into that.
Might be a good idea.
Okay. Well,
It is covered by insurance now.
Or,
so you might want to get a Arteria, I think it's Arteria. Yeah, it's not Arteria. I know that. I think it's Arteria. You might want to get an Arteria report. It's a good call.
Yeah.
Appreciate the feedback. Yeah, we'll do that.
And let us know where you want to go, and we'll and feel free to speak up, Michael.
Okay, I will. And I don't usually like to throw names around, but there's at least one doctor at Huntsman that I would that I'm not very displeased with, and that was Dr. Deckett. But I was told that the other urologists there were much different, but we run into the same problem because I've asked. You can't seem to get to see another urologist within the same practice if you decide you want to leave yours. So that's just my 2 cents worth. I was
Okay,
there. I was seeing him.
Yeah, I didn't recognize the name Deckett, but if you want to see a GU medical oncologist, we can give you a couple of good names. I can also give you one good name outside of Huntsman, who's at Intermountain, who trained under Agarwal. He's really a good guy. I know him through Telix. So we've got names. You just have to tell us where you want to go. Okay, let's move on.
Rick, I think the hands that were up have gone down.
No, I took a note. I took a note.
Oh, you wrote them down. Okay, very good.
Yeah, I wrote them down. Robert, we've got to move on. We'll come. Yeah. If you've got a comment, hang in. We'll save it till afterwards. But we've really got to try and move on so we get around everybody. Greg Burns, this is your first time in this group, isn't it? We can't hear you, so it's no good if I can't hear you, Mr. Burns. What am I going to do? All right. Yeah, that something came through for a second. Yes.
Okay. So yeah, I just wanted to get some feedback. Yes, Rick, you're right. I've been in active surveillance for 2 years. I was originally 2 years ago, about now 5.3 PSA, did a biopsy, an MRI biopsy. Long story short is I've gone from I went from a 1 core with less than 5% Gleason 3+4 to I just had another biopsy a few weeks ago, and I have now 3+4, 2 of which are under 5%, and 1 of them is 5%. Those are in the right posterior midline apex, the right posterior medial apex, and then the right base. The one that's 5% is the medial apex, I believe. So I've also had an MRI that said perineal invasion present, multifocal. I don't know what that means, but it also said, this MRI also said that the MRI I had in January said perineal invasion present, multifocal. It also said suspicion possible beyond the gland. Now, this is the exact same MRI, which also told me that my prostate volume was 81 cc's. But when I went back and actually, thanks to the group at the active surveillance, calculated it by putting the numbers length by width by height into the, and then confirmed this with my urologist, my mass is only 40. It's so this MRI somehow miscalculated the mass of the size of my prostate, which gives me pause. But at the same time, it's telling me it's suspicion of possible beyond the gland and perineal invasion present.
Yeah.
So I'm trying to get a second opinion on the MRI. I'm also getting a second opinion on the biopsy, and I'm getting a Decipher score. All of this hopefully will be in the next week or two, less than 2 weeks, because I have a meeting with my urologist on the 25th of July. So right now I'm concerned that I should start looking at treatment. I don't want to, of course, but I'm not sure if I've reached the tipping point or not. And so that's my conundrum.
Well,
What's
I
your
know
PSA right now?
6.3. It's
Thank
gone
you.
from 5.1 down to as low as 4.6, and over the last year, it's gone from 5.3, 5.6, 5.9, 6.3.
Mm-hmm.
Mark,
Go ahead, Rick,
John,
I'm sorry.
you start and talk to Greg, because I may have a bias here.
Oh,
Because
really?
I've been working with Greg for 2 years. So go ahead. You ask him the questions, and then I'll chime in with what I have
Well,
to say.
that's really all. I wanted to get an idea of the PSA trajectory and all this. I mean, it does seem like there's a very, very slowly growing, not aggressive, but also at the same time not sleeping cancer.
Correct. The lesion has grown from 1.2 cm to 1.4 cm since the last MRI a year ago.
Yeah.
Okay, so which lesion is that? That one in the apex, right?
I assume so. I don't really know, but I have all the 3+4s are the right posterior midline apex, right posterior medial apex, and then the right base, which, as I just heard from you, is not good. I didn't know that.
It's not good. So what we've got to do is try and find out if the lesion that's growing includes that apex, the base, or if that base is on its own. Where were your lesions before? Do you know?
Don't know.
Okay, so that's what I think at this point, rather than talk about treatment, let's talk about what you need to talk to your urologist about.
Okay.
And what you need to know is, how does that base lesion get tied in? And how close is it to the base? Because we already heard from Victor earlier on that he had extension into the bladder neck. And that's what we're really concerned about. The reason the base is bad is because the prostate is kind of upside down. The base is at the top and the apex is at the bottom. And you would usually think it's going to be the other way around, but it's not when we talk about the prostate. So where the prostate is attached to the bladder is called the base. And that's why we're worried about the base, and we're a lot less worried about the apex, because the apex is away from places where it might spread. It would have to go through the capsule. So we we're focusing in, and I think that, you know, with your Stanford guy, he's not going to push you into treatment if you don't need it. We know that your experience with him has been very positive on that. So we've got to be drilling down. Colonel Boykin, what's your thought?
Yes, I just want to ask, like, why can't you just go back and get another MRI if the first one might have errors in it, like you were talking about with the, you know, the volume size and some other things that seem confusing?
Yeah. Okay.
I mean, that's also a very good suggestion. So anybody else? I see, Robert, you've still got your hand up. Is that about what we're talking about now or something else?
Something else.
Okay, well, when we will be coming to you, so you'll we'll talk to you. So
is perineal invasion present? Is that serious?
So what PNI is perineural invasion. That was on my report. It's on a lot of reports. It's a very controversial feature. It basically means that nerve channels were running through the tumor. So the concern is, could that run back? Could that be an escape channel through the nerves? We generally do not think so. There is an association with perineural invasion and higher risk prostate cancer, but nobody's ever said it's causal. So we really don't know. We don't think means a heck of a lot. John, Dr. John, do you want to say anything else about PNI?
Oh, I completely agree with you. It's really the least worrisome of some of the aberrations that we see on the pathology report. It's just one more thing to tell us that things are slowly advancing, but it's not something that would immediately put you into a treatment category.
Okay, thank you.
Okay, Mr. Burns, if it's okay, we'll move on. Where are you, by the way? Are you
California.
here?
California.
Oh, you're in California.
I'm California.
Okay, just to let the other guys know, Mr.
Okay.
Burns.
Rick, it's okay. Please, no, it's okay. Thank you. Let's move on.
All right.
Okay.
Okay.
Appreciate
Goodbye.
it.
Goodbye.
Bye-bye.
Goodbye. Okay. We've got Paul and we've got Robert. Do either of you have to jump off right away, or can I take one and then the other?
I would like to go. I'm tired.
I'm so sorry, Robert. Paul, is that okay by you? Can you stay? Is Paul still with us?
I didn't have anything, Rick. I did not have anything.
Oh, okay. I thought it was somebody else. I thought there were two Pauls in here. I didn't realize it was you, Paul. Is it okay? Go ahead, Robert. How can we help?
Was it the person that had Dr. Mark Perlow on the screen?
Yes, that's me.
That's Robert.
Yeah,
That's
he's
Robert.
on twice.
Oh,
Go ahead,
okay.
Robert.
Got it. Okay.
All right, so I had a biopsy done last May of 2024. Came back with 3 plus 3, 2 3 plus 3s, and that was 5 millimeters. And one was a 3 plus 4, and that was 5% over 4. I went to maybe 6 or 7 different places, from the surgeons to New York City to different doctors, and eventually came back to getting a second opinion, as I've heard in these chats. Got a second opinion about a month ago, and it changed the 3 plus 4 to 3 plus 3s. So I've been on active surveillance, obviously, all this time. and I am scheduled for another biopsy next week. And my PSA has stayed at 7.1 in the last year, which is why I got the first biopsy done when it went to 7.1. So I'm at 7.1 still, and now I'm scheduled for another biopsy. And so,
what type of biopsy?
Excuse me?
What type of biopsy are you scheduled for next week?
It's not the one that I had already, which was
transrectal.
Yeah, it's not the transrectal. It's the other one he said.
Transperineal.
Yes.
Okay. And where is that scheduled for?
In New Jersey at a Summit Health Medical Facility.
Okay. And when was your last biopsy?
It was in May of 2024.
So this is less than a year.
It was actually June of 2024.
Okay, so it's less than a year, and
over a
little over a year.
It's 12 months. Okay, right. And was that your very first biopsy, the last one?
Yes.
Okay, so I'm not the best person here to talk about it. Some other people may, but there are a lot of places that want to do a confirmatory biopsy within 12 months. But then there's another school of thought that says you don't need another biopsy for 3 years if nothing has changed. Have they done the MRI for next week?
Yes, that was done about 2 months ago when I switched to this Dr. Esposito, and they showed no capsule.
It showed nothing. My suggestion to you to get a real good feedback on this is to join the AS group on Wednesday, and because there's going to be a lot of guys who have been in your position, and they will have peer experience as to whether they think you need to get to have another biopsy this week. I'm going to pick on Stuart again because I think he's been around this block a few times. What would your opinion be, Stuart? What would you do?
I can't hear.
We can't hear you. We can't hear you. He's gonna adjust that.
But that's why I'm checking in here, because my gut is telling me to wait on the biopsy.
Right. And I think you're probably better in the AS group, especially now since you're 3+3, than you are in this group. But I'm going to lean on Stuart because I know, or Michael, because I know that these guys are the AS experts that are in this group because I recognize them from the other group. What would you do, Stuart?
Can you hear me now?
Yes.
Okay. Nothing's changed on the MRI?
That changed was the second, when they read the slides the second time at Johns Hopkins, they changed the 4 to a 3.
Okay. Did the number of threes go up? Well,
no,
it doesn't really matter. If they're 3+3s and there's been no significant change in the MRI, I'm not really sure what you're doing. The other thing you could consider instead of another biopsy is you could opt for, well, I was going to say you could opt for some of the other tests, the blood tests or urine tests, but you already know you have diagnosed.
Right.
Yeah. I'm not, unless they have a real good reason why you should have the biopsy, I'm not convinced you need one.
I'm tending to agree. I'm kind of, it just would solidify that the change from the 4 to the 3 is still there.
Okay, so let me just ask you something because I'm sort of getting lost. The 3+4 was from a biopsy in what year?
2024, last June.
And so you haven't had a biopsy since then, right?
No.
So, but all you're saying is that when you ask for a second opinion, that 3 plus 4 was changed to a 3 plus 3. Is that correct?
That's correct. I sent the slides.
Okay, so I would rely on the Hopkins. So
Okay.
you are a gent who really should be in the AS group and not in this group, because right now we're not even talking treatment.
Okay, that sounds good.
So I'm going to suggest to you, like I did to Frank, please come back Wednesday, 8 o'clock in this room, and we'll have a bunch of people in the AS group to help you. Do you agree, Michael?
Michael
Okay,
agrees?
Mike.
I would
Yes.
definitely be in the active surveillance group. I would definitely go with my Johns Hopkins second opinion as what I thought carried the strongest weight.
Okay.
Okay. So
Good to hear.
there's the answer. We'll see you on Wednesday. And Paul N., did you ask for time, and how the heck are you?
All right, thank you. Be well, everybody.
All right.
Bye, Robert.
Bye.
Paul, are you there? Come in, Paul.
Yeah.
Yes.
No, I do not. I do not need time. Thank you for asking.
Okay.
I'm
Well,
fine.
I
Thank you.
think there was another gentleman called Paul, and he probably dropped off. So, is there
Yeah, that,
anyone else who wants to talk? Frank, what do you think? You've been sitting here all this time. What do you think?
I could see it's a very complex, I guess, problem to deal with. Um, our trash pickup has been on strike, and they're coming down the street now, so I got to get out my trash.
Okay, go ahead. Go ahead.
But,
That's okay.
but you asked one thing that pops into my mind. It seems like if you're in active surveillance, it almost seems like eventually you're going to come into this group, whether it's in 2 years or 5 years or 10 years.
Maybe. So let me answer that, and then you can go take your trash out. You're not in Philadelphia. You're in bloody Yorba Linda. I didn't know they were on strike in Yorba Linda as well as.
They're supporting them. They're supporting.
Oh, they're supporting them. So the old statistics, and they've changed a little bit, but they're not far off. And these came from Dr. Carroll's active surveillance cohort, and they've been a little bit updated. But he says that about a third of men on active surveillance remain on active surveillance always. They never progress. About a third of men progress, and about a third of men decide they don't want to stay with the active surveillance and they opt for treatment. So it's not necessarily true that you will finish up in this group, but there's a good chance you will.
Okay. Well, that's good to know.
Okay.
All right. And I'll see you tomorrow or Wednesday.
Wednesday. There's only one guy that's going to see us tomorrow, and I think he's left already. Thank goodness. Anybody else have anything before we sign off?
Thank you.
Okay. So would Dr. John and Stuart please remain? Boykin, you too. Jim, you can if you want. And everybody else, we're back on the 28th, Monday the 28th, and we'll see you then. All right. Good night, everybody.